Thank you very much for the invitation and for this wonderful summit. Well, this is the outline of my presentation. I'm going to try to talk a little bit about epidemiology. Unfortunately, we don't have good data, as was mentioned before, and the challenges and the recommendation. But at the end of this summit, this symposium, I hope that we will touch your liver as if we were touching your heart, and make sure that this fight against hepatitis becomes your fight. Well, no question that hepatitis mortality rates and viral distribution is a global public health problem. And unfortunately, Latin America is not, it's part of that problem. And in terms of Latin American hepatitis C might be a little bit worse than hepatitis B. And already it was mentioned that viral hepatitis, it belongs to the 7 cause of mortality. Unfortunately, we are not moving in the right direction because in 1990 we were on the 10th place. So this is one of the reasons why this summit is so important. Dr. Negro talked about good data. Unfortunately, we do not have good data in Latin America, but I'm going to present what we have. And this is the prevalence of hepatitis C, and this was a study that is being actually doing by the ALE committee, leading by Martin Tagle. And the prevalence in Latin America goes anywhere from 0.5 to 1.7%. Brazil and Mexico actually account for 2 of the 20 countries that have the 80% of the global burden of hepatitis C. And within Latin America, 85% of the burden actually is within these 8 countries: Brazil, Mexico, Colombia, Argentina, Venezuela, Peru, Chile, and Dominican Republic. By far, Brazil and Mexico account for most of the burden. In terms of the genotype distribution, genotype 1 is much more frequent in all the region. The second one is genotype 3, but that's only because it's very frequent in Brazil. If you remove Brazil from the data, then genotype 2 is the most frequent one in the rest of the Latin American country. In terms of hepatitis B, 3 things to know. 1, there's no good data. 2, it's probably decreasing because of the vaccination. But we are in an urgent need of better data. What about what the governments are doing? Well, unfortunately, only half of our country have a written national strategy for prevention and control of viral hepatitis. It's actually only limited to universal hepatitis B vaccination, which in fact is being taken by almost or all of our country, and by policy regarding to blood transfusion, especially for hepatitis B and C. All the blood units, or most of the blood units, are actually screened. In terms of official screening programs to try to detect the patients, either for hepatitis B or hepatitis B, is basically non-existent. As I mentioned before, only blood units are to be transfused, and mother who are, and pregnant women, they actually are screened. Unfortunately, not all of the country has a program to react for the patient or for the women who are infected. So what should we do, in turn to try to improve the screening? Should we use the original or the traditional way just to screen based on the risk factor, or should we adopt the age-based factor that it was adopted last year by the United States, where they realized that most of their patients actually were born in a specific ages, from 1945 to 1965. So the question is, in our region, which are our risk-based factor and which are our age-based factor? Well, for hepatitis C, no question that blood transfusion did play the major role. Probably not anymore. Unfortunately, we have another kid in the block, which is nosocomial transmission. And this, again, is an updated data from Martin Tagle's work. And as you can see, too many of our country, the herd-related transmission is way too high. In terms of hepatitis B, unfortunately, sexual blood transfusion and vertical transmission remains to be a problem. And somebody mentioned here the use of condom and a program to deal with the pregnant woman who is infected. What about age-based factor? Well, again, this is a work that it should be done in every country because it might be different in every country, and that hasn't been done. But this is data from Argentina, Brazil, and Mexico, and it looks like our baby boomers are a little bit younger than the ones in America. But this is a very important initiative to try to, we don't have too many resources, so we have to narrow our focus and narrow the focus of our resources. Another thing that we lack completely is referral system for diagnosis, follow-up, and linkage to care. So we need to implement that in each of our countries, but not only implement it, to encourage the patient to actually remain in those programs. What about burden of the hepatitis C? Every time that I talk about this, I always think about what should we explain to our policymaker to convince them that this is a problem. And I think the next few slides are very important to convey that message. Half of our patients, if they don't get treated today, they're going to become cirrhotics by the year 2030. And as you can see here on the upper left corner of the slide, the liver-related complication of viral hepatitis are hands to level of fibrosis. And unfortunately, if we look at, the question is, where are our patients in terms of fibrosis? If we look at 1990, most of our patients were F0 or F1. Unfortunately, nothing was done. And if you look at the data in 2016, that gap has narrowed significantly. So we lost a lot of time. Now, the number of F3 and F4 is almost the same as F0 and F1. So we must act now. And if we don't, then we're going to be dealing with all the consequences of advanced liver disease and the cost of this complication and the human cost of them. This is the kind of message that I think we have to convey to the policymaker to convince them that it's much better to treat than to wait. Even the mortality is expected to increase in all of our country. And another message that we have to make across to people who are not involved with the field, that we have a curable disease in hepatitis C and a controllable disease in hepatitis B. But not only that, that the benefit in terms of reduction of all-cause mortality, reduction of liver cancer, reduction of liver transplantation, and cost when you treat the hepatitis C patient or when you treat the hepatitis B is tremendous. It's much cheaper to treat than to wait. Especially because now we have fantastic drugs to cure hepatitis C and fantastic drugs to control hepatitis B. Unfortunately, this is the situation that we must change. Less than 10% of the population with hepatitis B and C have been treated, and in our country, less than 5% of those has been treated. And another message that we have to convey to our policymakers is this. If we don't increase the treatment uptake, it doesn't matter how wonderful drugs we have. We are not going to make an impact. If we want to reach the goal of 2030, we must implement a program where we increase not only the diagnosis through a screening, but also to treatment uptake. That will be the only way that we'll make a real impact. What are we doing? I gave a conference a little bit like this about 6 months ago in San Francisco, and actually I stressed that we were moving backward because the last 2 years we haven't almost treated anyone in Latin America. But I have to say that in the last few months, we are probably moving a little bit ahead, slowly, obviously not at the pace that we need, and this is what's happening in hepatitis C. About 70% of our country have some kind of government program. At least they are already addressing the issue, not even close at the pace that we need, and also there is availability of the new drugs on all of our country. Obviously, that's only the first step. To have the drug available doesn't mean that the patient has been treated. And also, there is a good national guidelines in most of our country, even though they need to be updated in some of them. And to give you an example, and this is what's happening now in few countries. In Argentina, already 1,500 patients have been treated. Brazil has been treating for the last 6 months and already have 20,000 people on treatment. Obviously, you have to realize the size of Brazil. That's half of what Spain have treated last year. And in Dominican Republic, which was the first country who had the sofosbuvir available, we have already treated around 200 patients. So we're moving not at the rate that we need to. Mexico is actually about to begin. In hepatitis B, it's a little bit worse in terms of government-provided treatment. But the drugs that are available and are available at a relatively good price. Guidelines are not as well as in hepatitis C. So what should we do to try to get this global strategy to make into place? Well, there's no question that we need to innovate and we need to accelerate this process. We have lost too much time. We don't have too much time to lose. We need to make intervention to cause real impact. We need the money for that. We need better information. Without data, we don't have power. But especially we need leadership. And so what will it take, in my view? Well, we need energy and commitment because we need to establish country and regional validated surveillance data collection. We need to implement screening, referral system, and linkage to care. But we must educate that when we treat patients and when we cure patients with hepatitis C and when we control the hepatitis B, we are decreasing mortality, we are decreasing suffering, we are decreasing costs. And actually, the treatment is cheaper than disease and never been more cost-effective than today. But we also need to increase the awareness of viral hepatitis, and this summit is a good example. But this has to move from here to the public. We need to prevent transmission. We need to increase universal vaccination. We need to improve. We still have problems with blood banks in our region. We need to strengthen safety practices. It's really a shame that someone get hepatitis B or C in the year 2016 in our places. We need to convince people that even treatment and cure prevent transmission. In order to get that, it's a must that have to be a collaboration between government, pharmaceutical, diagnostic industries, because we need to increase the level of detection, medical society, key leader of opinion to take this fight as a personal fight, and patient advocacy, because they are always willing to help. We need to democratize not only the knowledge, but also the care. Examples like ECHO or e-learning or visiting physicians are good ones. In general, or in summary, we need concrete and tailored action in each country. We need viral hepatitis policy for universal access and screening and linkage to care and treatment. But that treatment must be available at a rate or at an amount that actually will make a real impact if we really wanted to achieve the goal of eliminating hepatitis B and C by the year 2000. And before I finish, I'd like to invite you for the 24th Congress of the ALE, which is going to be held in Chile. Thank you very much.